got to leave, and I have just two points. First of all, I write them down.
Only you have to write them down too.
Okay. Well, the first point is, we've talked a lot about social determinants of health, and starting with behavioral issues or social issues. But I don't know that it needs to be said, but we are the medical system. We do have claims. We are accountable for costs. So it seems to me perfectly legitimate to start with the medical costs and start with claims. And I don't know why we have to keep going back there, but that's who we are and what we do. That's where we stand, and I think that's perfectly legitimate. Yes, we will have to create relationships with social service organizations. We have to deal with behavioral health, et cetera. But that follows our major mandate from society, and that's why they give us the money. So I think that's legitimate. Two other points related to that is, yes, it's true that some social service organizations don't quite have their act together, but there are other social institutions in our communities that would love to have partnerships with us. The corrections system, I can tell you that on our high utilizers in Medicaid, over half of them have been in the jail system. The jail system is part of the medical system. It is certainly part of the mental health system. When I went to talk to them about sharing data, they were overjoyed. Nobody had ever come to talk to them. There are huge opportunities to thinking about who else is part of the health system and who wants to talk to me. We don't have to pass money back and forth. We just have to learn to work together. Talking to the public defender, he was thrilled. He says, I'm tired of seeing the same people over and over. We need to talk about the plan that will keep them stable in the community. Let us talk. I mean, I think those are the conversations that are ripe to happen. And somehow we have to put that out there. I think there's also opportunities if you're dealing with kids, with schools, et cetera, right? So we need to look out there as who wants to talk to us. We are, we're sort of sitting on top of our mountain, and we need to come down and talk to the communities. So sort of related to that is I think that there is parts of our system that we haven't talked about that are critical. The addiction system is a disaster in the United States. I don't know a community that would say they have a really robust, adequate substance use disorder treatment system. In our population in Medicaid, 60% plus have substance use disorders. And the rate limiting step is the substance use disorders. And that's our issue. It's not social services. It's not behavioral health. This is, this is a medical issue. And the final thing I'll say is, nobody has mentioned trauma-informed care in this, and I think we have understood it. We're beginning to understand as a culture that a lot of these high needs populations have been extremely traumatized through their life course. We know about adverse childhood experiences. I think there's adverse life experiences. Substance use being one, homelessness being another, corrections is another. There is nobody in the healthcare system that deals with trauma recovery. When I first started learning about trauma-informed care, I talked to the medical director or the chief medical officer of a specialty mental health organization, and she said, you do not and we do not treat this disorder. This is the disorder that is driving most of your costs. And my experience for the last 5 years is probably that's true. There is nothing in our system, there's nothing in anybody's system to deal with this, and so we have work to do ourselves within our own system to be able to treat this high needs, high cost population.
Okay, great points. And again, please write them down. Can we get up on the slides Peter's Where We Go slide? I'd love everybody able to look at those. So you have the list and the outline, but even a higher level that you can be using. And I started seeing tent cards going up, so we're going to get to you all in a moment. But one last for the table, and I'll start with you, Dr. Wolof. One thing that while you were sitting with us today that you went, aha, I've never thought about that. I want to go think about that more. What's an insight that you heard today that is helping you think differently? Anything? The rest of you come next, so be ready.
Can I come back to you on that? Can I get a second to think about that?
Try it first. Nothing yet? Okay. Anybody of the four of you have one? Something that today you did not come into the room thinking about, and you now have. Anybody out there? Sure.
David, this is Jeff from the Peterson Center. The aha moment I had was a comment that you made this morning about, hey, we're really classifying the system or the modules in the system, and how can we get this system to be malleable, to move to the need much more effectively and efficiently. So instead of having to remodel a building or build a new building or build a new IT system or create new workforce groups, how does it flow? It's almost as if we're trying to hang an app on an IBM 360 mainframe with COBOL as the software. And so that was the aha moment I had today.
Thank you for sharing that. I'll give you one of mine, which was that I realized that I've been doing this with the group for 18 months, and listening to the policy people talking about some letters and numbers that I admit I had never heard of before, not just bill numbers, but and names of programs. This field is so big that those of us who come at it from the delivery side and thinking about quality of care, and those of us who think about measurement and patient empowerment, and versus those of us who've brought into the room current regulations, getting all of that together takes this large of a community, and it's going to be a real challenge to write this report.
Yeah, so one thing, as actually Helen Burstyn was talking and sort of describing shared decision-making measures and these new measures, and we're talking about holistic measures of care, goal-directed care for patient goal-directed care. I had this thought, and I didn't sort of say it well at the time. It's sort of like at some point, as a primary care physician, these people with 6 or more chronic illnesses, they might have 20 chronic disease and preventive quality measures that apply to them. And all of a sudden, at some point, I need to just, how do we find the way that we step back and say, none of these really matter right now. Let's stop, thinking about these for a second and instead get, how can we find that? It's been part of our work, but it really, now that we're getting better measures and measurement, it's sort of like, how do we just put those aside and then focus on the real needs of these populations where these other measures might be perhaps harmful to keep focusing on?
Yeah, I would actually echo that, and I'm a primary care doc like you, and I think in clinical analogies, it's sort of like the de-prescribing movement that we're seeing particularly among older patients, but really that we should think about for everyone, and we need the analog of that in the health system more broadly to really think about the things that we can peel off, particularly if we're adding some burden on. And because so much of this rests on the shoulders of primary care, I think that's really the hot spot, for thinking about this very carefully. Sorry, you just prompted that one, Dave, but the other one that I was thinking about that really crystallized for me today is the unintended consequences of fragmentation. And of course, these are related concepts, but just the idea that in our well-intentioned efforts to stratify and segment, we're introducing more complexity just by virtue of doing that. And for us, at Health and Hospitals in particular, our mission is to take care of everyone, regardless of ability to pay. In practice, that ends up being very hard to do because we're serving many different masters, from Medicaid managed care plans to Medicaid fee-for-service, for which we have a DSRIP waiver, to our uninsured patients. And so actually making it so that we can apply both our stratification efforts as well as our care models in a truly payer agnostic, whole population way is something that, unless you really bake into your efforts as an organizing principle, it's just the natural course that you're going to fragment. So I think one of Ashis's points was regarding frailty. So from a Medicare Advantage perspective, frailty is a bane of my existence. We screen from it from the moment someone enters the plan. We try to anticipate decline, and what you learn is frailty, one, in the literature, is a poorly defined concept, right? It just means slowness of movement, essentially, in Greek. And traditionally, what we associate with frailty, the cachectic cancer patient, is only one dimension of frailty. You can have morbidly obese frail people. You can have someone who's 40 years old and frail, right? So it's not necessarily age dependent, even though it's a risk factor. And so I've been trying to wrap my head around this for the last 8 months. How do you screen for it? How do you manage it? What are the different programs dedicated to each individual line? And he just distilled it into something far more utilitarian, which is, what is the threshold effect? And on a functional limit, what do you need to do to trigger certain programs, certain processes? And I don't think we do enough of that in terms of healthcare delivery.
All right, I think my aha moment today was MedStar's phenomenal program. I certainly identified with it and told Gretchen afterwards that I wish I had had them for the past 20 years working alongside me. The results might have been a little bit different. So I have an automatic action item, and that is to march into Senator Warner's office and get that piece of legislation sponsored and passed. So I'm ready to go.
What a great addition. I do have more for them, but I see lots of tents. I have not seen lots of people scribbling on cards. I'm really serious. Please, please give us your ideas. We're gonna, thank you, thank you. Woohoo. But would people like to join the conversation? And the main thing, this is a chance you don't have to ask questions, you're welcome to do that, but really to say to this larger community, here's what I think we need to include as we build this report. Things that are missing, things that need to be highlighted, things that are wrong, things you want to see from a policy, a delivery, a research, implementation, spread. So the cards are going up. These are the same. Everybody whose card up right now wants in. Okay, we have about 30 minutes. And I'm just going to start and we'll just work across. Is that okay? So please.
Green, hi, good morning, good afternoon. I think I just had a little bit more caffeine. My name's Carol Regan, I'm with Community Catalyst, and I feel like the way Melanie said something this morning about so many things to say but not enough time, so I will try to keep it at a very specific recommendation, like I think Arnie talked about being action junkies. So a lot of us at Community Catalyst are action junkies, so I have some really concrete things to say. One is, I heard a lot this morning. I was glad that some of my colleagues from National Partnership and other folks, even Julian, talked about really the importance of, we call it consumer engagement, other people call it patient engagement, patient empowerment, but how important that is moving forward. And let me set up a couple of things. We just finished some focus groups with consumers in a couple of states about their long-term services and supports needs and what they felt was really quality and person-centered care. And a lot of, we'll be sharing that soon, but a lot of what came out of there is people really said, we want someone to listen to us, right? I want my doctor to listen to us. I want them to ask me what's important to me. And I don't think we can't pass that over. That's really important. And it happens at a lot of levels. So they were very clear at the patient level. They want to be listened to about their goals and what's important to them and what they need. And their care coordinator, they mentioned their care coordinator too, some who don't even know who it is, but know when they heard that that was a thing that they were supposed to have, they were like, oh yes, I really want that, to your point. Second is they really want to be involved. And so when I come to the solutions part here and the path forward, solutions must include them. And I think in terms of the action steps, I think we have to invest. We can't just talk about the importance of the community in terms of population health or community-based organizations. I think we need to really include them, include consumer and advocacy and disease groups and caregiver groups, because they know what they need in their community. And I think Julian mentioned, I think there's a perception, and I would love to see this addressed in the report, that to change the frame of how we think about it and being viewed as a burden. Oh my God, we have to have a consumer advisory council. Oh God, it's going to take so much, and we may have to pay for it. You know, to really understand that, and even one of our colleague I know on the AARP board who was at Dana-Farber said very eloquently, I try to tell my colleagues, this is great. This is not a burden. This is like really makes a difference because it improves your outcomes. So I would encourage all of us to not think about this as just a box to check, but this is really fundamental reform that is about the patient. And two other points I wanted to mention. One is I worry that the frame here doesn't include action needed to really build in a level of consumer engagement at the individual level, but also at the plan level and the system level. And that we avoid talking about this as it's about them. So we're going to do this for them, policymakers and plans, and that this is sort of bake it in, as somebody said earlier, into system change. And I guess the last thing I would say about that is that Community Catalyst, National Partnership, a lot of our consumer partners here have an infrastructure. You know, we're involved in about 40 states around the country. We've got local groups, we've got state groups. We have folks who are really ready to be engaged. They just need to be asked. And I guess my final comment was, it reminds me of years ago when our allies in the disability community were really getting organized and talk about nothing about us without us. And I think that's a really important thing to think about, whatever. And I think I'm so pleased, Marianne, what you said is we've got to engage people not afterwards, but in front of it. And we're more than happy to be that interlocutor.
Thank you.
So thank you.
much.
Good afternoon. I'm Lauren Harden from the National Center for Complex Health and Social Needs with Jeff Brenner. And I just wanted to call out two principles that I've heard, but I haven't heard us explicitly say we would want to include this in the report. One is that what we've heard from model review and our findings is that we would support interprofessional collaboration. So we're not talking about a physician-centric model, a nursing-centric model, a peer-centric model. We're talking about really valuing interprofessional collaboration as a solution. And then a second principle would be interorganizational collaboration towards a solution. So it's not about payers only, it's not about hospitals only. It's collaboration across systems that's going to result in really good solutions for this population. And then one other principle, so before I joined the center for the last 7 years, I've been working directly with complex patients, and my own dad was a super utilizer, so personal experience and professional. But in the frail population, I think the other principle we've consistently been calling out but not explicitly saying is that trust and consistency is crucial. So whether you have a trauma history, whether you have fragmentation in your delivery because what's paid for only lasts for 90 days, or whether you have fragmentation, breaking that consistency from transitions in care, trust and consistency is critical for the solutions.
Excellent. Thank you. Why don't we move to the table in the back?
Thank you, Gretchen Alkema from the SCAN Foundation. Carol said lots of the things that I wanted to say, so ditto. And the spirit in that is specifically include the definition of person-centered care from the JAGS 2016 article, what was developed by an expert advisory panel that gets to almost everything that Carol just said. Associated with that, I was thinking about Ashish's comment with his conversation with Prabhat about that thresholding question that was also kind of brought up on the panel. And I think it's easy to forget that in that thresholding question that is undergirding that is a concern of woodwork effect, or that's the fear that lives out there as well. You know, we're going to create this program where we're not going to target really well, and everybody's going to come and they're going to want everything at every moment in time, and they're going to live in my hospital, and they're not. and the evidence of that is it Veronica this morning, who is our wonderful caregiver? Veronica this morning. I just loved what she talked about with her mom. And, you know, if we take a step back, her mom was somebody who had access to both Medicare and Medicaid, you know, the trifecta ultimately of payment opportunity for all things that she might need. And her mom's goal was still about not going anywhere, being at home. And she didn't want all that intervention. And she probably had, you know, a chart that was as big as this table, you know, by the things that she was talking about. So just remembering high needs, high cost individuals really don't want to come and see any of us who are in healthcare delivery. Like success means not going. And sometimes I think the healthcare delivery system has a confirmation bias that forgets that, of saying, no, everybody wants to come and see me because we're really important, and they really don't. And then the last thing I will say on the policy front is just an acknowledgement that policy, and I mean big P and little p in that, really needs to consider both the federal and state levels, and most importantly, the interaction between those two. I was doing a talk on person-centered care yesterday morning, and this gentleman was talking about how they had built this, and I don't know the reality of this, but I'll just say his experience was they built this really incredible kind of person-centered culture change long-term care type facility. I don't know what it was. And he said the state people came in and basically said, you know, you're violating 16 different kinds of rules here in terms of your care delivery model, because they had a survey assessor who was looking at, you know, from a really narrow regulatory standard. So remembering that we can dream up big things that are cool at the federal level, but they don't always translate to state unless we do some things to help kind of marry that down, which also gets down the delivery systems of, and I just think about the 2 different states, the 3 different states particularly, you know, that the gentlemen are working in, and how radically different it is from New York to Nevada to Oregon, and everybody in this room. So thanks.
Thank you. Rick.
Thanks. Rick Kronik, UC San Diego. 2 suggestions for the draft outline, one relatively smaller and one relatively bigger. You might want to reject both of them. The relatively smaller, on the panel that I was on, we had quite a lot of discussion about the state of the art, or the state of the not art, of quality measurement, and the need for, you know, really serious investment if we're going to try to improve this. Ashish, in his comments, mentioned, well, some number of millions of dollars in a $3 trillion healthcare system should be okay. I might say some number of hundreds of millions of dollars, which is a scary number, but, and I don't know what the number is, but I don't think it's more than millions. It's, you know, got more zeros on it. But if we're going to make progress and rely on these measures, there needs to be a really serious investment in them. Second, and I think bigger, and you may well not want to go there, but there has been a variety of discussion today about the fact that this is not likely to save money, or it's not clear whether it will save money. And even if it's, I would say, and I would go a little further and say, even if it saves money on these patients, at least in a system that has still got a lot of fee-for-service, it's not clear it will save money altogether, because somebody else may end up using more services. So I think, and you know, whether the committee and the National Academy wants to go there or not, I'm not sure, but you know, at least if you haven't seriously considered, I would encourage you to seriously consider whether you want to say an investment in primary care and care coordination is needed. It may end up saving money, but it will lead to improvements in outcomes that patients care about, and that's why we're spending money. And even on you know, the earlier discussion, if there were 2 million people at $5,000 a person, that's $10 billion. Well, that's a lot of money for Medicare. It's 1.5% of annual spending, and you know, this is a population we care crucially about. Again, might sink the report if you went there. You might not want to do it, but it's a notable omission.
Aren't you glad you're not in government anymore?
It's a wonderful thing.
David, can I briefly react to just one of those comments? Which is that, very briefly, I'll just say it's, it reflects our healthcare system as a whole that we have great measurement burden, which Larry Casalino had a nice paper, I think, in Health Affairs that showed that it was something like $25 billion when you total up how much health systems and practices actually spend to meet the measurement burden that is required of them, but we don't have the upfront investment to make sure that we have a parsimonious measure set that is actually sensible from the perspective of patients.
Worth it. Lucy.
With Consumer Reports Healthcare Value Hub, I think that what the planning committee must do is decide, are you going to lead with social services or not? And everything flows from there. If you do not lead with social services based on the evidence that's available to us, I would say you have to take the word bold out of your news article. If you do lead with social services, and your rationale, I was a little bit offended by that fellow over there. The medical professions, you know, is famous for first doing no harm. That means it is not about the doctors, it is about the patient. And if you are going to do as well as you can by the patients that fall into this category, I think that leading with social services there, because as Jen said, you don't want to go to the doctor. Can we keep them out of the doctor? That's our measurement of success. So if you make that decision, it does imply things about your report. For example, that means you have to get into financing because there are all these models on the ground, and the problem is not measurement sets or anything like that. It's that they can't find the damn money to provide the housing support, to provide the air conditioner, the sidewalk, whatever the hell it is. So you need to add that to the report, a discussion about where does the money come from to take these models that appear to be working to get the social supports in that people need. And what we have up there is alternative payment models. And that implies that if you call that money, like the means of production, the means of getting to success, you're implying we give it all to providers, like to ACOs, as Ashish said. And that is not necessarily where we want to put the money. We may want to put it with the community-based organizations. They may do a better job. I'm sure in your prior meetings where I wasn't here, you discussed the wrong pocket problem. So I don't think it's a good measure of success whether or not ACOs decide to invest in housing because it saves money. I just think that's not a rubric we can use at all if you broaden your lens. So if you go down this route, I think another useful addition to your report would be talk about ROI. ROI isn't a fixed concept. It's almost a philosophical concept. What do you think should be in there? What should be out of there? What's the time horizon? I think that a lot of what we need to do in the policy space and the local space is make the business case for these models. And that means there is a rubric for determining ROI. So I think that's a useful addition to your report. And again, there's just a very interesting conversation there. I'll close up here. I could go down ROI for a long time. The other thing I'll say is I think the evidence about cost savings is a little bit better than has been presented here. And perhaps that is because I am so firmly including these social services inside of what's being discussed. But even if the cost savings is neutral, the data on outcomes is very good. So isn't that a go when you spend the same amount of money and get a better outcome?
So thank you for saying, you can model it. If we're wrong, tell us, the rest of you. Thank you. And you wrote it down too, so double thank you. Yes.
I just want to say, oh yeah, for lack of a nicer term. We have seen, I think, consistently, I'll speak from my community, things that emanate from the top down not working so well. Things that perhaps are going to start from the bottom up with a community focus have a much better chance of working. I talk to family caregivers day in and day out. I know my own experience quite well. And, short of starting within the community, I mean, even those services that are available today, families don't know they exist. There is no 1-800 find me a service number to call to locate services in your community, whatever that might be that transportation, food, companion care, it doesn't matter what it is. But, there is a serious gap today in, knowledge coming to families about what is available and how to take advantage of it. And the three worst words in the English language are you don't qualify. And we've got to figure a way to get around some of those hurdles as well, but definitely the community up approach.
Okay.
So Lucy Savitz at Intermountain. And what I'm going to say, I don't want to in any way be construed as diminishing the importance of informal caregiving, the role of communities, and a lot of the issues that we've been talking about. But as you're writing the report, I would just make the plea that you think about how we can think about implementation of these things. I was sitting here thinking about all the things we've been talking about today, and I can tell you with 100% certainty if I went into any primary care practice in my delivery system, they'd be like, we can't do one more thing. And a lot of what we've talked about, we know, like with shared decision-making, patient-reported measures, that you need to move it upstream. And so a large part of this burden is going to be on primary care. And one of the things I found is that the argument is not always about asking people to do one more thing. It's about how to do what they're already doing better. And I think if we can sort of cast a lot of this in that way, it doesn't have the same burden on the people delivering some of these services.
Oh, I so much want to follow up, but I'm going to restrain myself. In the back table, I see a card.
Oh, great. Thanks. Thank you. Prabjot Singh. I'm with both the Peterson Center on Healthcare and Mount Sinai Health System. Great to hear a colleague from New York City, Dave, speaking about the healthcare delivery challenges. I wanted to mention a couple of things. I think actually Dave's point about how do you end up knitting together the interspaces between all of these components that are being discussed is a primary and central challenge. And I'll offer something that may be worthwhile for us to consider. We spend a lot of time both at the center as well as Mount Sinai Health System thinking about how do you actually sandbox areas of work where you need to kind of remove constraints, remove rules, remove financing regimes, productivity regimes, IT requirements, regulatory requirements in order to do that bold breakthrough experimentation. And it's a, you know, you can't just pull everything out. There's a bit of an art to how you actually frame that sandboxing. And what you end up realizing is that it takes a lot of synchronization of system assets that you may not even have realized. You realize that focus is so quickly lost if you have to have multiple actors involved in executing anything, and that you have to actually define what constitutes a breakthrough for any of this to be bold, for any of this to actually achieve its intended goal. And as we think about sandboxing or experimentation at various levels, at a system level, I think that there's a lot worth considering or writing about how do you end up going about starting to do this knitting together, that discovery process. How do you start removing constraints in ways that sound sensible and not crazy? And then potentially at higher scales. What does sandboxing look like for a Medicaid program or for a payer to participate in that process? You can use different language around instead of sandboxing, but I think the idea there is, you know, qualifying what a breakthrough looks like, what's going to be required to enable that to work, and how much latitude would you be willing to give in that environment in terms of time, finance, or otherwise in order to allow it to achieve its ends.
Thank you. Can I see, just a show of hands, how many folks haven't spoken that already had their cards up? I think it's 3. We're on perfect speed. So we're going to come to this table last. So
Lauren from the National Partnership, and ditto Carol, Gretchen, Len, and the panel. But so I won't spend time on that. But one thing that I think is perhaps beyond the scope, but I'm going to toss it out there in case it's not, in terms of policy mechanisms that can help move this work forward. When you talk about the ability of caregivers or care partners to participate in helping to meet the needs of their loved ones as a partner, so you're not shifting burden, but they're part of the solution, looking at what keeps them from getting involved. Do they not have paid leave? Do they risk losing their jobs to go to an appointment? So I think broadening our view in terms of where are there other policies in terms of how employers construct their benefit packages, including leave, or what state law or federal law is on that. And there's a lot of action going on in terms of the Family Act. But I think we ought to look broadly in terms of some of the policy barriers beyond medical and social care financing that could move this work forward.
Thanks. David Atkins from the VA. So I'll just begin with the observation that, you know, we have a lot of advantages at the VA that many of the stakeholders here don't have, and it's still been very hard for us. So we have an integrated system. We can pay for housing. We can pay for these social services and we can integrate it, and we don't have a fee-for-service model. And yet the challenge is still there. So I just want to remind people that we shouldn't minimize, we shouldn't make it sound like this is simple and set up expectations that then people will go, wait a minute, you promised me that this would be great. I think my biggest insight was actually from a lunchtime conversation with a colleague from Camden, where the idea was, you know, the medical person is probably the least important person on the team, and that their model really doesn't even require nurses anymore for their teamlet. And I think about our experience, and we're probably putting too much emphasis on the medical component as driving the benefit of this. And so, and I heard that with the comment from Lynn about the social, emphasizing social. And I also resonate with the idea that this is going to be driven by patients. And that's a way to kind of flip the model on its head if we think of it as a bottom-up, patient-driven emphasis on the non-medical components that are driving healthcare. So as a research funder, I would like more advice about what the questions are. Jerry listed a long list of questions we haven't answered, and I need help thinking, okay, help me identify the top several of those. From my top of the head perspective, one obvious one is research designs, okay? I think there's a lot of danger in models that don't have strong enough controls, but when I hear about the fact that the returns may not be in the first year, well, we probably can't afford to do a 3-year randomized trial of these things. Maybe we can, but so how do we balance the need to get long-term outcomes while we're controlling against confounding regression to the mean? The second is, touched on only briefly, is sustainability. In the pilots that we've been doing, we run into this problem that we can't keep the patient in the program forever and make room for new patients. And yet patients don't, and we're not dealing with people so sick that they're dying enough to create openings. It's very traumatic for the teams and for the patients to say, you've loved it for a year, now you're going to graduate and go back to your primary care. So thinking about sustainability of these programs is critical. The second is this, which is related, is the challenge between continuity and customization. So we heard a lot about what really makes these things work is a single, reliable person, the engagement, the personal connection, the trust. Well, how do you do that and also recognize that there are 6 different models and maybe now you need a different model? And so can you build a team that can do it all, or do you have 6 different types of teams? One for high risk, seriously mental ill, one for homeless, and we struggle with that. We have lots of different silos that take care of little pieces of this. It doesn't promote the continuity issue. And I think that was it.
Okay, last table. Susan.
Foundation. I think the technical aspects of this work are daunting enough. I think what might be even more daunting are the sort of cultural or adaptive aspects. I think we're talking really about moving power, moving decision-making, moving money amongst very broadly medical systems and social service systems and community, and then between patients and providers and community. And I think that when you get down to the, actual coalface level and even, system leader decision-making level, that is a big issue. And it goes beyond just having, representatives of patients on even community governance boards. It's a real big issue. And along with that, I think is the issue of trust, at the individual patient provider level. I think so many of us know that, the trust element is not only crucial, but really lacking. And I think that if you're really trying to change things, that's another big issue. A little easier, but still very hard on the technical thing is really training in managing addiction at the primary care level. I have a few others that I won't bore you with, but one more I'm going to bore you with, I wrote them down, is actually tapping on and supporting the community level, really individual person-to-person support, a la LIFT model, where I know you don't want to hear about another model, but the idea is really that you build up of the person's and the community's own resilience, and that's what we need to do, particularly to address the kinds of things that you're talking about. Some people can never be moved out of highly intensive care, but some people can, and maybe the medical bit can be reduced if you have the community level stronger. So thank you. And I also want to say the huge amount of incredible work and bravery after having done all of this toil in opening it up to all of us. I really, really, really commend and thank you.
Okay, Randy Brown from Mathematica. I did fill out my little card here, so I'll keep this real quick and just mention two things. One is we talked about patient engagement, caregiver well-being, measuring quality, patient-centered care, and yet one thing that never got mentioned today that accomplishes all these with a net cost of zero for some segment of the high-risk people is consumer-directed care, home and community-based care. That's not all the group people that fall into Melinda's group are covered there, but two of them are, people with disabilities and frail elderly. They're some of the highest cost, most disadvantaged people. And having done evaluations for almost 40 years now, this program, which we did with random assignment, is the single most effective program I ever evaluated. Huge effects on caregiver health and as well as well-being, and on patients' quality of life. So cash and counseling, consumer-directed care more generally, but yeah, so that didn't get mentioned at all today, despite the fact that it addresses many of these issues. And if you have consumer-directed care of this, and you put social stuff at the front, then you can also get them engaged in the medical care more easily. So anyway, I think that's a big gap. The other thing that is the matching of, we talked about, which models work best for which patients. Wrong question, I think. There are components that are going to be needed, but basically you need the continuous caregiver with the pipe wrench, if that's what she needs today, to solve the problems that the patient has at the time. They need the flexibility to do that. So we have to balance this. On the one hand, you got people saying, if you have a model and people kind of pick and choose which of those components of the model they implement, then it's not going to work necessarily, even though it's been proven if you are faithful to the model. On the other hand, you got patients' needs that vary all over the place. So I think every single program I've ever heard of for care coordination that worked, the first thing they say when you ask them, well, what is responsible for your success? They say, oh, we got outstanding care coordinators, care managers. They're just unbelievable. And so you got to give them the flexibility to do that. It can be within a general context of the model, but you can't take away the freedom to do what they know needs to be done better than anybody else.
Excellent. Thank you all. Since the panel was brave and came up here and did this first, I want to give them the last word. And so my question for you all is, what haven't we let you say that you want to say? So ask your own question and answer it, but the only thing is you get 1 minute. I'm sorry. We'll start, we'll go back.
Sure. First, let me just echo the very well-deserved plaudits to the organizers of this. This is one of the most thoughtfully designed workshops that I've come to. So thank you, Peter and Melinda, and everyone else who was involved. The comment that I wanted to make is on language. And I would just point out two things about the draft press release or article that was put up. The first is that I noticed the dateline said New York, so that's a lot of pressure on those of us in New York. But the second thing, seriously, is that I think we have to continue evolving our language in how we're actually talking about these issues, particularly to the really thoughtful comments from folks about how we need to bring the patient at the center and engage communities. And language is so critically important to be able to do that. So with the humility of Monday morning quarterbacking on that article, I think just the simple idea that we need to move from saying super utilizer to high need patients to something that's even better than that when we're talking about these issues. So I would just put that forward.
Excellent. Perfect comment. A lot of pressure.
Do my best. So what really inspired me to go down this path was some work that I did in a rural part of Ethiopia that was funded by USAID, and it was a quality improvement project. And every morning when I'd wake up and walk towards the hospital, there was a sign, the USAID emblem that said, "From the American people." And it was just like this this gaze over me, like, are you doing things efficiently? Is there a return on investment? Are you actually making a difference? And you know, being a part of Medicare Advantage delivery, I don't think is any different. Like, these ultimately taxpayer money, and if it means that we have to reconceive how we deliver care, we have to ask ourselves, what is care delivery? You know, we've all spent a lot of time in clinical training. We're all obsessed with the micromanagement of numbers and details with respect to clinical care, but we have to understand that there are many other components. So it's actually been a genuine pleasure to be around so many like-minded people looking for all the complementary aspects of care delivery. And if it means we have to reconceive care delivery and turn it on its head and think of effective substitutes that actually increase the utility to the individual patients, to the individual members of the population, I mean, that's what we need to do. Whether it's a for-profit company like mine owned by Anthem or someone at the population level in New York City, it's what needs to be done, and it's going to take a lot of resolve and patience and thoughtfulness, and I have full faith that the people in this room will get it done.
I'm going to call you Dave Marianne, but on this panel, you're an honorary Dave. Sorry.
So I appreciate, and this is why I wanted to switch with her. One of the things that I did when we received our first dissemination grant for our model of care from the John A. Hartford Foundation in 2007 is they sat me down and said, this is not normal research. You may put your academic career at risk. And I have never looked back on that with anything but happiness, because everyone teaches me so much, and I feel like what we just got right now in these comments was a lot of teaching about that people who have these needs, their needs are not getting met in our society. And this is what we're here for, right? To hear this and to take it in. And I especially appreciated the comment from Susan that this is a massive cultural change for researchers, for health systems, for the medical system. And so I look forward to taking this report and sort of going on further working with all of you.
Thanks, Dave. And by the way, my husband would be the first to tell you I always get the last word. So, at least at my house. And Randy, I was actually going to mention consumer-directed care because I work on technology to that end, but I didn't have enough minutes. So, but here you go. I just mentioned it. Very important. I think what we're doing is culture change on a grand scale, probably that's never been done before in this country. You know, I think we all need to encourage our peers that it's going to take some patience, maybe one or two do-overs, maybe a left or right turn along the way, but it is definitely doable. And I want to conclude by saying, forgive me if I'm a bit emotional about this. I lost my mom in May. She was not only a 42-year breast cancer survivor, she spent 40 years as a registered nurse and practiced not only in this country but around the globe. And I will tell you, I can honestly say that I hope the integrity with which she practiced as a nurse is the integrity with which we will move this project forward.
Please join me in thanking the panel. Katie, are you here? Did she leave? Oh, yeah, she's right here. Katie is the keeper of the cards. Okay, so really, we do want those written comments. You can, of course, give them to me, but this is my partner in crime, so please share them. And Peter, I turn it back to you.